That's the first of the organism. The next one is C. auris. Is it an infection control problem or an antifungal resistance? And Tom Chiller is going to talk on that. And again, I made up that topic, and so you have to deal with it. He's laughing, so let's see what he says.
Well, good morning, everybody, and it's really great to be here. And I sense a sort of I feel a little different at this meeting. So I'd say, John, maybe this curriculum that Pete talked about that you put together, it feels a little more invigorating and different and fun, and I feel there's a little more energy in the room. So I thank you for doing that and also allowing me to talk about a topic that I didn't pick, because I sort of like that. You picked the title, as you said, so I'm going to run with it a little bit and just see what comes out. But again, thanks for having me. And my disclosure, as usual, I'm a fun guy. One of the things that keeps me up at night more and more now are these animal fungal pandemics that are happening. And at first, I think we all learned about white-nosed bat syndrome and the chytrids in frogs, and we heard from Matt Fisher and other people about these issues. But they're freaking me out a lot more these days, because basically we're putting that long-eared bat on the endangered species list because of a fungus. And we've had extinction of frog species because of a fungus. And so, even though thankfully we don't have pandemic fungi in our species yet, they're certainly showing their potential in others. So Candida auris was a ear infection in 2009 from Japan and then Korea. We didn't honestly pay a lot of attention to it. I mean, we saw it get reported, and okay, fine, another Candida species that's causing an external infection. Okay, and then of course we know now that that's changed. In fact, we stopped updating our global map in February of 2021. We just couldn't keep up with all the places where it was being reported as either a single case or endemic, et cetera. So clearly this thing has spread, and I don't think I necessarily thought that I would see a fungus sort of emerge out of nowhere and be pretty global within a 10 or 12 year period of time. So clearly this is giving us, as we all know, a sort of a different perspective on a yeast. And I always like to say this is a yeast that's acting like a bacteria, because it's highly drug resistant. We all know that, or at least it can be. It colonizes the skin, but also the environment, like readily, and especially in healthcare settings. I mean, it gets everywhere. And then, of course, it spreads, unlike most Candida, in those environments. And so we see large outbreaks that are occurring, or smoldering sort of outbreaks that occur over long periods of time in some of the different types of healthcare facilities. So let's take a look at least our tracking of this organism over time, and I think you can see that we had our first case around 2015. We did our big announcement about this bug in 2016, and I don't think it was just an artifact of finding it because we talked about it. I think truly it emerged around this time, and you can see that COVID. At the beginning of COVID, we got no reports, probably because everyone was dealing with COVID. But then it was almost like throwing a bit of lighter fluid on the fire, and it has taken off. And in fact, in our recent sort of COVID report about co-infections, I think C. auris was up 60%. And it reemerged in places that it had some control over it, which obviously was disconcerting, but maybe understandable considering the infection control practices that weren't happening, because other infection control practices were happening to protect healthcare workers. So we understood that there were things going on with PPE, et cetera. But you can see here both clinical and screening cases have dramatically gone up. And I think that one of the things that illustrates this a bit is some recent events in Nevada. In fact, we just did an investigation with Nevada. They had their first clinical case in 2021, but you can see 8 months or 7 months later, they had over 100 clinical cases. I mean, this is the most rapid sort of expanse in clinical cases that we'd seen in any state. I mean, dramatically. Sometimes for a state to have up to 100 clinical cases, it's taken years. They saw this surge followed by subsequent surge in colonization, but which is usually the opposite. We usually see it colonizing first, and then we start hearing reports of clinical cases. So clearly that's a tip of the iceberg. If you're already seeing clinical cases, you know it's widespread in its breadth in terms of colonization. And then the other thing that was relatively unique was this surge was mainly driven by acute care hospitals. And that we haven't seen as much. It's generally the long-term acute care, the V-SNFs that we talk about, skilled nursing facilities, ventilated skilled nursing facilities. And then they had, for the first time, transmission of pediatric cases. So we had seen a pediatric case here and there. I think it was less than a handful, less than 5 that had been reported. But here we actually had, within a cardiovascular unit, cases. So clearly there are challenges in caring for these patients that are colonized with C. auris, because ultimately that's where we think a lot of this stuff is spreading from. Clearly it's hard to implement more robust infection control programs and deal with this organism, especially out of the acute care and into the longer term care. We have to use a higher level of disinfectant. This list P as they call it at the EPA, but basically more sporicidal type agents, C. diff type disinfectants. We've also had the challenges in hospitals taking patients that are labeled as a C. auris colonized patients, and they're obviously always asking us, well, how do we decolonize? And we all know in infectious diseases, is there such a thing as decolonizing, or are you simply trying to control the source down to a level where it's not transmitting anymore? And when we look at C. auris, actually, we were initially thinking this was more of a axilla growing type of a swab, but you can see here now we've, in recent work that's been done several different places, the anterior nares, you can also isolate it quite readily. And I think this next slide looks at some of the sites where you see it, and you can see the anterior nares is up there. So we're sort of rethinking, where do you swab someone if you're trying to grab a quick swab and understand whether your patient is colonized or not. Well, we heard Mahmoud talk about the microbiome, which is fascinating, and this is the skin microbiome. He was referring a lot to the gut microbiome. But what we found working with Julie Segre at the NIH and others is that there's sort of two different types of patients. Those that are colonized on the skin with C. auris have a very predominant C. auris colonization from the fungal microbiome. Those that don't have C. auris colonization have more of a Malassezia sort of microbiome, so maybe that's the healthy. What's interesting is we haven't seen a lot of healthcare transmission through healthcare workers. And in fact, when we've done studies on the few times when we've been able to swab healthcare workers, they don't have much C. auris at all. And so you wonder then, is it because they're not in the hospital sick and their microbiome is actually protective, and so C. auris doesn't colonize them? Whereas we know with many patients that have had lots of healthcare exposure, their microbiome seems to change and allows C. auris to predominate, or at least this is the sort of the hypothesis. A lot more work obviously to be done in this area, but to me it is interesting that the healthcare worker themselves are not getting that much C. auris colonization. This is just to show then how the patient seems to colonize the environment, and these are two different studies that were done by Joe Sexton in our group looking sort of at bed rails. And so what he basically did was, as you can see the graph, I guess on your left, is just on the y-axis, it's bed rail colonization. On the bottom, it's patient colonization. You can see it sort of goes up. The more colonized the patient is, the more you find on the bed rails. And I know many of us, right, who work in infectious diseases, we used to wear ties when we round, and I would lean on the bed rail. I've sort of completely stopped doing that. Like, I'm scared of the bed rail now. It's heavily contaminated with C. auris in places where there's C. auris. It is the best place to go looking for it in the environment. So you can see here a couple depictions of that. And so that bleeds out into where C. auris is in the environment. And you may not find it on healthcare workers, but wow, you find it everywhere in these rooms. And, you know, if you use quaternary ammonium, which is sort of the holy water of disinfection in our hospitals, that just spreads it around. It just sort of moves it to different places. It doesn't kill it. So you have to up your game and use bleach, et cetera, and some of these sporicidal products. And I think that's what's contributing to the infection control challenges that we're having getting rid of this organism. Just to talk a little bit about this colonization, I don't know if any of you attended, and I'm stealing a few slides from Joe in our lab, but there was an FDA meeting, I think it was last week, on colonization and colonization endpoints. And FDA is very interested in how do a decolonization study, how do you design that? You know, people have been working with CHG and chlorhexidine and all these other things, but the FDA hasn't really had an endpoint for saying, we're gonna approve this as a decolonizing method. And so it was interesting. They had a big meeting for a day on decolonization, and we talked a little bit about C. auris, because C. auris is one of those bugs that we're wondering, can you aka decolonize people? So these are a couple mouse model studies that looked at that a bit, and the one on your left is Mahmoud's work, where he tried to look at terbinafine and clomitrazole as options. I always thought terbinafine would be a really fascinating way to decolonize someone with C. auris, because you could give it according to the onychomycosis treatment strategy, 1 week every month for 6 months, and you could, and you get these incredibly high levels in skin, and wouldn't that make a great way to decolonize? And so I think Mahmoud looked into that, and he got a little bit of response, but it certainly it didn't eliminate it. So anyway, I think we're challenged with trying to figure out how we can decolonize, or as we like to say, reduce the pathogen reduction, source control, to address this colonization phenomena, as well as with other MDROs where we're concerned about colonization. We also really could use some standard laboratory models to help evaluate the efficacy of decolonization. And so this is what we sort of called for in this FDA meeting that we had recently. So that's sort of my take on infection control, which was one of the questions. Is it an infection control problem? I would hope you see, yes, it is an infection control problem. But now let's switch to the other question that was on there, antifungal resistance. Is it an antifungal resistance problem? Well, this hasn't changed much in the collections of isolates that we have. We're still seeing sort of, majority azole resistance, about a third polyene resistance, and still a small amount of echinocandin resistance. So those numbers overall, as we're getting more isolates in, haven't really changed much. And this just gives you sort of a graphical depiction of isolates that are coming into our 7 antimicrobial resistance labs. So we have 7 labs around the United States that can receive C. auris isolates, and they test them for both species and AFST. And so these are not trends, so don't use this as a trend. This is just individual sort of prevalences as they come in at different time periods, and you can sort of see as more isolates come in, it dilutes down the percentage of resistance, but you still sort of get a depiction of what we're seeing. And so obviously the big concern here is this pan resistance, or this multi-drug resistance phenomena. And so we had early on in 2020 3 pan resistant cases in New York. They were unrelated, so they emerged sort of as individual cases, and they developed resistance on echinocandin treatment. So they were already resistant to azoles and polyenes, and then they developed echinocandin resistance on treatment. when we did extensive sampling around these cases, we didn't find any of those similar organisms hanging around. So we thought, okay, maybe these were isolated phenomena. We don't have to deal with the fact that these isolates have set up shop. And of course, we had already heard that pan resistance had been reported in several other countries. But this is what it sort of is starting to look like now, and you can see some of the data coming in on pan-resistant or a echinocandan resistant, which we think is the real challenge with these isolates when they are echinocandan resistant, and then there's still some that we're still working up. But you can see that it's clearly increasing, even though these are still very small numbers. And then more recently, we had several clusters of highly resistant C. auris in Washington, D.C. and in Texas. You can see here the cases were found to be having transmission, so they were related in these two clusters. And so this was really the first report of transmission of these highly resistant, either echinocandan resistant or pan-resistant C. auris organisms in healthcare settings. And that, to me, is the big concern. They didn't have any prior echinocandan or other systemic antifungal treatment, so they arose essentially de novo, or they came from somewhere. And that's been, I guess, my biggest fear on the resistant side of Candida auris is this going to be the future? Is this isolate or these types of isolates are going to slowly replace all those other ones that are out there? And if so, we're obviously going to need, changes in how we manage these things. And we've obviously heard a little bit already at this meeting, and there's probably more drugs than just the Ibrexa and the Phos-Man that I put up here as options for C. auris. It sounds like there are some other ones coming, which is fantastic. But I also think we really need to be thinking about, combination therapy up front for some of these organisms. And I know New York did some in vitro work to look at 5-FC as an addition and we've heard a lot about 5-FC with crypto. Maybe it could work as an additional drug with these highly resistant organisms. So, I think what's next, from at least in terms of public health and how we're going to think about this organism. Our first strategy was any single isolate that we find with a state, with a clinical lab, work with them to contain, and control. Stomp it out. I'm just saying that here publicly that I don't know if that's what we can do anymore. You saw how widespread this is and how many isolates are out there. Do we throw in the towel to a certain extent on that kind of control, and we just accept the fact that this is here to stay in the milieu? And then focus all these prevention efforts on these highly resistant, because we don't want the highly resistant strains to then come out and be colonized in everybody's nares. So screening for, maybe a screening test for specifically for resistant C. auris. And then, of course, thinking about colonization, et cetera, strategies. And we wrote this article on what might explain the rise of this, because I'm still flustered and troubled about where this came from. And I know it was isolated in the beach of southern India, but there's also people on those beaches, so I don't know if that's truly an environmental isolation, chicken and egg sort of phenomena. But I know Demetrios mentioned climate and environmental changes, still speculative, but something to think about. And then finally, this article by Maren McKenna on the next deadly plague. And again, I bring you back to those animal species that no longer exist because of fungi. And again, this is what sort of keeps me up at night. With that, I will remind you all that we're coming into Fungal Disease Awareness Week. This is the 5th one that we've had. So MSG has been an incredible participant in that, and we know you'll be another one in this coming week. So thanks again for the time, and sorry I was a little bit over, John.